Right, we're with Jon Develing and Phil Heywood from Specialised Commissioning. They've just done a great presentation this morning. Just going to pick up a few points subsequent to the presentation. So, hi guys.
Hi.
I suppose the first question for me would be, obviously you were the North West Specialist Commissioning Group and now you're Northern Specialist Commissioning Group. How are you finding the challenges of covering the footprint, the bigger footprint?
So I can take a lead. I think the only way to do something on that sort of size, because we're talking about a combined population of Denmark and Sweden in terms of the gravity of it, and a budget of £3 billion, is to do it in conjunction with the three teams. So Phil and I are now doing interim roles in terms of the leadership, but you still need to do it at a local level. So what we've been trying to do is to gather intelligence about what does the North look like, where are the services provided, understand things like contract baselines, and then assimilate that into what that means for the North of England. That will then inevitably ask a lot of questions about access and about different rates and about different funding methodologies, and that's when we then work through the three groups to gather further intelligence. What it doesn't do is answer all the questions, but it does start to give us a benchmark in which we can say, what are BCT contributions to these budgets? Are they at the right level? And plan on going forward.
I suppose moving on from that then, I suppose sort of more of a finance question. What are the challenges in aligning the budgets? So you're talking about £1.9 billion before to £3 billion afterwards.
There are significant challenges. I think the difference between the 1.9 and the 3 is we absolutely know where the 1.9 is, so we actually commission that now. The difference between the two, it's lost in PCT budgets, and unpicking those with the trust in the PCTs is very challenging. I spoke about the algorithm. The building of an algorithm to identify that is the way in which we're trying to pull that together. But the nature of anything, it needs lots of iterations. I think the final thing in building the budget, if you get it wrong, you can undermine the whole NHS if it's too big of a budget, too small. I think the other thing that's really complex is the fact that the budget that doesn't belong to the CCG, this real temptation to refer, and the classic one would be the headache that Jon mentioned on the presentation. Headache, does it go to secondary care where I'm dealing with it, or does it go to the tertiary centre where they're not paying for it? So we need to get rid of those disincentives to do the right thing, the right pathway.
Aligning the 3 billion is going to be a challenge, isn't it? It's right, we know where the 1.9 is. We know the 3 billion is real because that's the cost of the service, but we need to identify the bit that's in the middle and understand where those costs are currently sitting, and then apportion those costs to the right contract and the right commissioner for the future, because it will be a commissioning budget, not a CCG budget. And the danger is that we don't triangulate that between the three parties, so the trusts need to agree with the PCTs that need to agree with Specialised Commissioning to make sure that actually on a tripartite basis we're all in balance. So that's what we refer to as stock take, stabilise and shift work. So we're stock taking where the expenditure is now and agreeing it, stabilising it, in other words, we're not moving it without a really good understanding of where it is. And then once we've got that and that's in place, and we have agreement between the three, that's when we can shift it into the right budgets.
Right. Okay. And moving on from that, in terms of, you mentioned the CCGs come up a couple of times today. What if any, is the interface with the CCGs and
I think it's a clinical interface, because CCG is about clinical commissioning, and that doesn't mean that Specialised isn't clinical. But we do need to make sure that CCGs are empowered to align their own actions with that of the commissioning of the board. So we need to make sure that CCGs are fully aware that when a GP refers a patient into secondary care, that referral could end up in tertiary care. And very often, referrals from GPs will just go into secondary care and say, please see Mr. So-and-so and give me some advice. That patient may end up in tertiary care, not with advice, but with treatment.
Yeah.
So you need to help GPs understand that they can do things to affect specialised services, because at the moment I think the specialised service seems remote, but they're actually not remote because they're part of their referral pathway.
Yeah.
And if they begin to understand that, then I think they can begin to understand how they can impact their behaviours on specialised services. And we've been doing some work with clinical commissioning groups within something we call an integrated care project, which says these are the things, GPs, that we think you can do differently. And if you do these things differently, we think that will also help slow down or reduce the expenditure on specialised services. But more importantly, get the right outcome for patients. Because patients very often present in specialised services in an ad hoc and in an inappropriate way. So it's good for the doctors, it's good for the patients, and it's good for the costs.
I think the other thing I would just support is actually getting how do you get the feedback to the CCGs, and that's why we're trying to show a mechanism of displaying transparently where the contracts are, what's happening, and it isn't always evident. If you start to compare rates per 1,000 population, 100,000 population of referrals and etc., it starts to give them part of the story. So it's not over there specialised commissioning. It starts becoming actually something we can tackle, and it supports what Jon's just said. So that's the information flow.
So moving on from there, you mentioned the quick frameworks this morning that you developed. How will they progress going forward? And how do you see the importance of the quick framework?
60% of the budget that we hold in the north of England for specialised services can be attributed to around about 5 or 6 actual pathways: cancers, neurology, mental health, children's, and nephrology or renal care. Most of the budget is actually aligned in that way. That's not to say you can save 60%, but there's an opportunity cost greater in those services than in some of the other specialised services, such as transplantations or burn care, etc. So we're trying to focus on those areas that have integrated care. We then looked at each of those areas, looked at the activity, looked at whether those areas of greatest growth within those specialties, and try to hone in on those areas of the greatest growth where we can bring about the greatest change. So, bad backs, spines, earlier renal care, cancer detections, inappropriate referrals into mental health services, and so we've looked at those, and then we've developed what we call the quick frameworks, and we displayed some of those this morning, and then said, on those pathways, what 3 things can a GP do differently? What 3 things can secondary care do differently? What 3 things can the clinical networks that are part of those pathways do differently? And what 3 things can tertiary hospitals or specialised commissioning do differently? So we tried to build it in 3s for each patch, and then we give that guidance to PCTs or the CCGs, and that's why I talk about clinical champions in CCGs and taking that and implementing that locally, because we can't possibly get to every CCG in the future, but rather give them the tools or the areas that we think they can bring about change on, and then it will be them to deliver that. Deliver it in the incentive, but that will reduce their referrals into tertiary centres, and perhaps in the future realign the NCB budget, to some of it to come back to the GPs, hopefully incentivising the system.
Yeah. Okay. I suppose the last question for us would be around the SUS data set that you mentioned this morning, and you mentioned that possibly the data in it wasn't complete enough. Can you tell us a bit more about how you...
I think there are a number of areas in SUS. SUS doesn't hold all what is called the minimum data or clinical data sets that are mandated. It only holds those agreed that go through SUS. So within specialised commissioning, areas that don't go through that process are things like mental health, or the pass-through payments for all drugs and devices doesn't go through that. It's got a huge part of the budget. So when you're applying algorithms and stuff to that, you're only getting parts of the answer and parts of that. What we need to do is use all the data sources we've got to expand what we've got there, to really understand how do we identify specialised services. So such is brilliant, but only is one part of the jigsaw. The other parts of the jigsaw we need to pull in. I think I mentioned them again. There's things like the renal data set cancer registry. There's one called PICINET, Paediatric Intensive Care, and TARN. All of those we need to pull together somehow. We get extra outcome evidence as well. What's quite clearly missing is more clinical evidence within the data sets to say have you really got value for money.
Thanks a lot for your time,
Okay.
guys. Cheers.
Yeah, cheers.
Welcome.